Welcome to this audiobook entitled Rhinosinusitis. As a way of introduction, rhinosinusitis is the inflammation of the paranasal sinuses caused by mucin buildup. Most people are familiar with acute rhinosinusitis, abbreviated as ARS, and chronic rhinosinusitis, abbreviated as CRS, which are viral or bacterial in nature and usually associated with the common cold. Fungal rhinosinusitis, abbreviated as FRS, presents another level of complexity because its complications may be fatal. Rhinosinusitis affects about 1 in 8 adults annually. Rhinosinusitis has significant economic implications because of the cost of provider visits and treatment. Indirectly, CRS is responsible for lost wages and decreased productivity within the workforce, according to Rudnick 2017. Rhinosinusitis also negatively affects quality of life, especially for those with CRS and FRS. Although rhinosinusitis is a common health problem, currently available treatment guidelines are conflicting. Treatment is usually left to interpretation of differing guidelines published by several sources, and clinical studies provide limited data. We will now discuss acute rhinosinusitis. As a way of background, acute rhinosinusitis is a self-limiting inflammatory condition of the nose and paranasal sinuses lasting up to 4 weeks, according to Benninger 2003. Viruses predominantly cause ARS, creating the subtype viral rhinosinusitis (VRS). Growth of bacterial pathogens can occur at any time during VRS because of sinus drainage obstructions or nasal bacteria collecting in the sinuses, creating a second subtype known as acute bacterial rhinosinusitis, abbreviated as ABRS. Acute VRS transitions to ABRS in less than 2% of all cases. Viruses or bacteria in the sinonasal tract cause mucosal thickening, subsequently creating trapped mucus secretions and inflammation. Symptoms of VRS generally peaks within 3 days before gradually resolving after 10 to 14 days. Cases of ABRS can last up to 4 weeks. Recurrent rhinosinusitis occurs if a patient has 4 or more episodes of ABRS per year with no persistent symptoms of rhinosinusitis between episodes, according to Rosenfeld 2015. Regarding the microbiology, the most common viruses causing VRS are rhinovirus, influenza virus, parainfluenza virus, coronavirus, adenovirus, and respiratory syncytial virus. Rhinovirus is the predominant virus associated with VRS. The predominant pathogens in ABRS are Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus, according to Ahng 2011. Regarding clinical presentation and diagnosis, characteristic presentation of ARS includes purulent nasal drainage, either cloudy or yellow, nasal obstruction or congestion, facial pain, pressure, or fullness, and possible fever or headache. The hallmark of rhinosinusitis is inflammation of the sinonasal tract and concurrent inflammation of the nasal mucosa, according to Ahng 2011. Diagnosis of ARS is symptom-based, as shown in Table 2:1. Viral rhinosinusitis is assumed if signs and symptoms have been present for less than 10 days and do not worsen during that time. Acute bacterial rhinosinusitis can be diagnosed if signs and symptoms persist longer than 10 days, or if symptoms worsen over 10 days, or after initial improvement, also referred to as double worsening, according to Rosenfeld 2015. The diagnosis of ABRS differs between the practice guidelines from the American Academy of Otolaryngology, Head and Neck Surgery Foundation, abbreviated as AAOHNSF, and the Infectious Diseases Society of America, IDSA, Table 2:2. Radiographic imaging should be reserved for patients who present with a complication or for those thought to have an alternative diagnosis, according to Rosenfeld 2015. Regarding therapy, treatment of VRS should be supportive. The same is true for initial treatment of ABRS. Symptom management includes relief of mucopurulent nasal discharge, nasal obstruction, headache, fever, and fatigue. Symptomatic relief can be achieved with adjuvant options, as shown in Table 2-3, according to Rosenfeld 2015. In addition to symptomatic relief, initial management of ABRS includes watchful waiting or initiation of antibiotic therapy. Antibiotic therapy should be initiated if the patient will not follow up. Watchful waiting is reserved for patients when follow-up is ensured, according to Rosenfeld 2015. Antibiotic therapy is initiated if signs and symptoms do not improve within 7 days or if they worsen at any time during watchful waiting. Guidance regarding initiating antibiotic therapy differs between the AAOHNSF and the IDSA. See Table 2-2. Pause the video and carefully scrutinize Table 2-1 summarizing the classification of rhinosinusitis. Pause the video and carefully scrutinize Table 2-2 summarizing the comparison of ABRS diagnosis and treatment recommendations from the AAOHNSF and IDSA. Pause the video and carefully scrutinize Table 2-3 summarizing adjuvant therapy used for ARS and CRS. Regarding pain relievers, pain management with analgesics or antipyretics such as acetaminophen and NSAIDs may be initiated for the relief of facial pain, headache, or fever. Pain relievers should be selected on the basis of the severity of pain, according to Ahing 2011. Both the AAOHNSF and the IDSA support analgesics for relieving the pain associated with rhinosinusitis. Next we will discuss nasal saline irrigation. Nasal irrigation is superior to traditional nasal sprays, according to Egan 2009. Nasal saline irrigation may decrease symptoms and the need for adjunctive therapy for patients with ARS. Patients who have used nasal irrigation for sinonasal disease reported statistically significant improvements in symptom severity and duration, according to Tomuka 2000. Hypertonic saline solutions are recommended because they provide a greater anti-inflammatory effect than isotonic and normal saline solutions. In addition, saline solutions thin mucus and improve sinonasal drainage better than saline nasal sprays, according to Rosenfeld 2015. Nasal irrigation is a safe therapy that is associated with minimal risks and adverse events, according to King 2015. Regarding antihistamines should be used with caution because they can cause overdrying that can irritate the mucosa and increase discomfort. In addition, use of antihistamines may thicken mucus production and increase sinus blockage, according to Ahing 2011. No studies support the use of antihistamines for VRS or ABRS. Support for using oral antihistamines in VRS is based on their anticholinergic properties providing relief of excessive secretions and sneezing, according to Rosenfeld 2015. Use of antihistamines for symptomatic relief of ABRS is not supported by the AAOHNSF or the IDSA. However, the AAOHNSF does acknowledge antihistamine use in patients to decrease sneezing and congestion when their symptoms support a significant allergic component, according to Rosenfeld 2015. Regarding decongestants may provide symptomatic relief of ARS by reducing mucosal edema, allowing for improved sinonasal drainage. Topical decongestants such as oxymetazoline provide sinus relief, but treatment is limited to 3 days to prevent rebound congestion and rhinitis medicamentosa, according to Rosenfeld 2015. Despite the widespread use of decongestants, data are limited on their efficacy for ARS, according to Ahing 2011. The AAOHNSF supports decongestants as adjuvant therapy for both VRS and ABRS on an individual basis. The IDSA does not support decongestants for ABRS because the adverse effects associated with decongestants outweigh the benefit of their use. Regarding mucolytics, mucolytics are believed to thin mucus secretions and improve sinonasal drainage, according to Ahing 2011. Minimal data are available to support or oppose the use of mucolytics for ARS. However, favorable risk-benefit profiles of mucolytics like guaifenesin promote the use in ARS, according to Kushner 2011. The AAOHNSF supports mucolytics for relieving the symptoms associated with VRS and ABRS on an individual basis, depending on patient and provider preference, according to Rosenfeld 2015. The IDSA does not discuss the use of mucolytics for ABRS. Regarding anticholinergics, anticholinergic nasal sprays such as ipratropium bromide reduce nasal drainage by inhibiting mucin production by the mucus glands. However, as previously mentioned with antihistamines, use of anticholinergics for ARS is controversial. Anticholinergics may worsen or prolong ARS by thickening mucus and increasing nasal blockage. Use of anticholinergics is not supported by the AAOHNSF or the IDSA. Use of anticholinergics is often based on patient and/or provider preference, according to Scheid 2004. Regarding corticosteroids, nasal corticosteroids may relieve facial pain and nasal congestion by decreasing mucosal inflammation in patients with ABRS, according to Rosenfeld 2015, Chow 2012. A slow onset of action has limited oral corticosteroids from being used as adjunctive therapy in ARS. A systematic review found a statistically significant difference in the mean number of days a patient reported that it took for symptom improvement or to be cured, 6 days with intranasal corticosteroids versus 9 days with placebo, according to Loon 2013. Several systemic and topical agents are available, as shown in Table 2-4. Dosage and duration depend on the severity of the condition. Regarding antimicrobials, empiric antimicrobial therapy should be initiated in patients presenting with signs and symptoms of ABRS only. Guidance regarding the administration of amoxicillin with or without clavulanate differs between the AAOHNSF and the IDSA guidelines. See Table 2-2. The IDSA guidelines recommend empiric therapy with amoxicillin, clavulanate for 5 to 7 days in adults. The IDSA guidelines prefer amoxicillin, clavulanate to amoxicillin alone because of the increasing prevalence of Haemophilus influenza and the high prevalence of beta-lactamase producing respiratory pathogens like Haemophilus influenza and Moraxella catarrhalis in ABRS. The AAOHSNF guidelines recommend amoxicillin alone for the treatment of ABRS as a safe, effective, and low-cost option with a narrow microbiologic spectrum. The AAOHSNF guidelines reserve amoxicillin, clavulanate for patients at high risk of being infected by an amoxicillin-resistant pathogen. Factors that would prompt the initiation of amoxicillin, clavulanate include antibiotic use within the past month, close contact with children, immunocompromised patients, health care providers, presence of moderate to severe symptoms, recurrent ABRS, age older than 60, or pre-existing comorbidities. For these high-risk patients, both the AAOHSNF and the IDSA recommend high-dose amoxicillin, clavulanate. In penicillin-allergic patients, doxycycline or respiratory fluoroquinolones are recommended by the AAOHSNF and the IDSA. In addition, the AAOHSNF recommends combination therapy with clindamycin and a third-generation oral cephalosporin in adults with a history of non-type 1 hypersensitivity to penicillin, according to Rosenfeld 2015. Therapy for resistant ABRS depends on initial therapeutic management. If initial management includes watchful waiting, initiation of empiric therapy is warranted. If patients are initially treated with amoxicillin without clavulanate, high-dose amoxicillin, clavulanate, doxycycline, or a respiratory fluoroquinolone can be initiated. If ABRS is refractory to amoxicillin, clavulanate, the AAOHNSF recommends second-line therapy with macrolides, tetracyclines, and trimethoprim, sulfamethoxazole. However, the IDSA does not recommend these agents because of the high rates of resistance in Streptococcus pneumoniae. In severe infections requiring hospitalization, the IDSA recommends intravenous therapy with ampicillin, sulbactam, ceftriaxone, cefotaxime, or levofloxacin, according to Chow 2012. Dosages for preferred products can be found in Table 2 to 5. Pause the video and carefully scrutinize Table 2 to 4 summarizing systemic and topical corticosteroids for ARS and CRS. Pause the video and carefully scrutinize Table 2 to 5 summarizing antimicrobial therapy used for bacterial rhinosinusitis. Next we will discuss chronic rhinosinusitis. As a way of background, chronic rhinosinusitis is defined as rhinosinusitis with signs and symptoms persisting for at least 12 consecutive weeks. Chronic rhinosinusitis is primarily an inflammatory disease with acute exacerbations, ABRS, according to Rosenfeld 2015. Chronic rhinosinusitis includes three subtypes: CRS with nasal polyps, abbreviated as CRSW-NP, CRS without nasal polyps, CRSs-NP, and allergic fungal rhinosinusitis, abbreviated as AFRS. Allergic fungal rhinosinusitis will be discussed in a separate section. Chronic rhinosinusitis usually presents in patients with predisposing conditions such as asthma, allergies, cystic fibrosis, polyposis, and immunocompromised states. As such, treatment for CRS involves identifying and managing underlying conditions. Regarding the microbiology, Staphylococcus aureus, Prevotella, Porphyromonas, Fusobacterium, Peptostreptococcus, Pseudomonas aeruginosa, and other anaerobic and gram-negative bacteria are the predominant pathogens associated with CRS, according to Brook 2011, and Benninger 2003. Regarding clinical presentation and diagnosis, the four cardinal signs and symptoms of CRS include anterior and/or posterior mucopurulent drainage, nasal obstruction, facial pain or fullness, and loss of the sense of smell, according to Meltzer 2011. Mucopurulent drainage presents as opaque white or light yellow, according to Rosenfeld 2015, Chow 2012. In the latest practice guidelines for adult sinusitis, the AAOHNSF emphasized that the diagnosis of CRS cannot be based on signs and symptoms alone. Rather, objective evidence of sinus and nasal inflammation is required to prevent overdiagnosis of CRS and costly and unnecessary tests and interventions, according to Rosenfeld 2015. Objective evidence can be obtained through direct visualization of the sinuses using nasal endoscopy, CT scanning, or MRI. Nasal endoscopy should be a first-line confirmatory test, according to Rosenfeld 2015, whereas CT scanning and MRI should be reserved for patients with complicated presentations of CRS. Confirming the presence or absence of nasal polyps is necessary for developing an adequate treatment plan. Culture of secretions plays no role in the routine management of uncomplicated ABRS, according to Rosenfeld 2015. In patients with ABRS whose first and second-line empiric therapies have failed, culture should be obtained to identify persistent bacterial infections or resistant pathogens. Regarding treatment, goals of therapy include reducing mucosal inflammation, improving sinus drainage, eradicating the colonizing or infecting pathogens, and, in CRSW-NP, reducing nasal polyp size, according to Poromchai 2011. Managing CRS includes initial therapy to reduce and manage signs and symptoms, followed by maintenance therapy. Initial therapeutic options for treating CRS consist of systemic corticosteroids in combination with antimicrobials. Adjuvant treatment with nasal irrigations, topical nasal corticosteroids, or long-term macrolide therapy may also be warranted, according to Rosenfeld 2015. In addition, surgical measures may be necessary to remove any obstructions to improve sinus drainage. Maintenance therapy for CRS is managed with nasal saline irrigation and topical nasal corticosteroids, according to Meltzer 2011. Regarding nasal saline irrigation, for CRS, the AAOHNSF recommends nasal saline irrigation for symptom relief. Nasal saline irrigations reduce postnasal drainage, remove mucus secretions, and cleanse the nasal cavities of bacteria, irritants, and allergens, according to Harvey 2007. High-volume nasal saline irrigation is superior to low-volume nasal saline sprays, Thomas 2013. Nasal saline irrigation should be used as adjunctive therapy to intranasal corticosteroids for patients with CRSW, NP and CRSs, NP. As monotherapy, nasal saline irrigation is associated with less symptom improvement, according to Rudmick 2015. As with ARS, hypertonic solutions are preferred to isotonic and normal saline preparations because of superior anti-inflammatory properties. Regarding nasal corticosteroids reduce underlying inflammation, improving sinus drainage and nasal airflow, according to Joe 2008. In patients with CRSW-NP, nasal corticosteroids decrease the size of nasal polyps and prevent the recurrence of postoperative polyps, according to Kalish 2012. A systematic review showed significantly improved polyp size in patients treated with intranasal steroids compared with placebo, according to Joe 2008. Nasal corticosteroids should be used for long-term management of CRS in patients with or without nasal polyps, according to Rudmick 2015. Regarding systemic corticosteroids, in CRS, systemic corticosteroids are used for many purposes. The anti-inflammatory properties of systemic corticosteroids manage acute exacerbations of CRS and manage CRS in patients with comorbidities such as asthma or allergic rhinitis, according to Poetka 2012. Short courses of oral prednisone have been studied with dosing 30 mg daily for 4 days, followed by a 2-day reduction of 5 mg. This was then followed by maintenance therapy with a topical nasal corticosteroid, 400 mcg of intranasal budesonide twice daily for 12 weeks, for the treatment of CRSW-NP, according to Benitez 2006. Systemic corticosteroids can also be used at high dosages to maximize therapy before considering surgical interventions and used perioperatively to reduce inflammation, according to Hisaria 2006. Regarding short-term oral antimicrobials, no antibiotic is approved for the treatment of CRS. Antimicrobial use is based on historical practice rather than evidence, according to Su 2011. Treatment should include broad-spectrum agents such as amoxicillin, clavulanate, clindamycin, trimethoprim, sulfamethoxazole, levofloxacin, and moxifloxacin, according to Su 2011, as shown in Table 2-6. Amoxicillin, clavulanate is usually first-line therapy for most patients. If community-associated methicillin-resistant Staphylococcus aureus is suspected or the patient has an allergy to penicillin, monotherapy with clindamycin is recommended, according to Kane 2013. Most patients with CRS can be treated with oral antibiotics. However, patients who have refractory CRS, who are seriously ill, or who are non-surgical candidates may benefit from intravenous therapy. Ceftriaxone, clindamycin, levofloxacin, moxifloxacin, and vancomycin are usually used in these patients, according to Bhattacharya 2009. Antimicrobial therapy lasts 3 to 4 weeks, depending on the severity of symptoms, duration of CRS, and prior exacerbations and treatment courses, according to Su 2011. Pause the video and carefully scrutinize Table 2 to 6 summarizing the antimicrobials for CRS. Regarding long-term macrolide therapy, macrolides can be used long-term to manage CRS. Because of their anti-inflammatory properties, macrolides may decrease symptoms of nasal obstruction and postnasal drip, improve sinus drainage, and decrease nasal polyp size in CRSW-NP. Long-term use of macrolides in CRSs-NP has been associated with improved symptom relief and mucociliary clearance, as well as improved quality of life, according to Wallwork 2006. Macrolides are also effective in recalcitrant CRS, according to Servan 2007. One study suggested use of daily clarithromycin 250 mg or azithromycin 250 mg for at least 12 weeks for optimal results, according to Solar 2009. Regarding topical antimicrobials, topical application of antimicrobials such as mepiricin, in conjunction with nasal saline irrigations, is safe and effective in CRSW-NP, according to Vaughan 2002. Mepiricin irrigations provide ongoing mechanical debridement of irritants, pollen, bacteria, and fungi in patients with CRS, especially in postoperative patients and those with persistent purulent accumulations, according to Solers 2006. Use of high-volume 240 ml mepiricin irrigation has improved symptoms short-term in patients with an Staphylococcus aureus positive sinus culture, according to Jarvis-Brady 2012. However, a systematic review of topical antimicrobials showed that routine use of these agents for CRSs-NP is not recommended, according to Rudmick 2015. Regarding nebulized antimicrobials, evidence is limited to support the use of nebulized antimicrobials such as levofloxacin, ciprofloxacin, and ceftazidime, which have been shown to be safe and effective in patients who cannot tolerate standard therapy, or those with refractory CRS, according to Woodhouse 2011. Nebulized antimicrobials have been associated with prolonged infection-free periods in postoperative patients with CRS, according to Lim 2008. In addition, nebulized tobramycin has been associated with a lower incidence of revision surgery in patients with cystic fibrosis and chronic rhinosinusitis, according to Luck 2017. Patients offered nebulized agents preferred them to traditional oral or intravenous routes of administration, according to Vaughan 2002. Regarding leukotriene antagonists, efficacy data for symptom management with leukotriene inhibitors like montelukast, zafirlukast, and Xileuton in patients presenting with CRSW-NP are mixed, according to Kane 2013. In randomized controlled trials, montelukast reduced vasodilation and mucus secretion compared with placebo, according to Rudmick 2015. The most improved symptoms with montelukast are headache, postnasal drip, and nasal pruritus, according to Mustafa 2005. Compared with inhaled corticosteroids, no differences have been observed, according to Rudmick 2015. However, leukotriene antagonists were more favorable in a subjective assessment of smell, according to Wenzel 2013. Typical dosing of leukotriene inhibitors is listed in Table 2 to 7. Regarding biologics, data are limited to support the use of biologics for CRS. However, biologic agents such as omalizumab, mepolizumab, dupilumab, and rislizumab have been proven safe and efficacious in recalcitrant CRSW-NP, according to Rudnick 2015. Improvements in polyp score, CT scan, individual symptoms, and quality of life have occurred with the administration of omalizumab after 16 weeks, according to Gavart 2013. Administration of mepolizumab for 8 weeks has improved polyp and CT score compared with placebo, according to Gavart 2011. In combination with mometasone fumarate, dupilumab decreased nasal polyp size compared with mometasone monotherapy, according to Backett 2016. Reduced nasal polyp size has occurred after one infusion of rislizumab in patients with increased nasal IL-5 interleukin-5 concentrations, according to Gavart 2006. Type E cal dosing of biologics is listed in Table 2 to 8. Pause the video and carefully scrutinize Table 2 to 7 summarizing leukotriene antagonists for symptom management of CRS and Table 2 to 8 summarizing biologics for CRS and FRS. Next we will discuss allergic fungal rhinosinusitis. As a way of background, allergic fungal rhinosinusitis is a subtype of CRS that accounts for 5% to 10% of cases, according to Hoyt 2016. Allergic fungal rhinosinusitis is a result of an allergic reaction to fungi colonizing an obstructed sinonasal tract. Regarding the microbiology, fungi commonly associated with AFRS belong to the Dermatiaceous or melanized group of fungi, according to Revankar 2010. More specifically, these melanized fungi include Alternaria, Bipolaris, Curvularia, and Drexlera species. Aspergillus species has also been associated with AFRS. The causative fungi is identified through histologic culture and evaluation. Regarding clinical presentation and diagnosis, allergic fungal rhinosinusitis presents with the classic characteristics of CRS, anterior and/or posterior nasal mucopurulent drainage, nasal obstruction, facial pain or fullness, and anosmia. Patients may present with green, black, or peanut butter-like mucin. Hoyt 2016. Complicated AFRS can present with bone erosion and nasal cavity expansion. 5 main criteria have been proposed for the diagnosis of AFRS: presence of nasal polyposis, evidence of atopic disease or type 1 hypersensitivity to common fungal agents, eosinophilic mucus without fungal invasion, characteristic CT findings, and a positive fungal smear, according to Bent 1994. As with the other types of CRS, AFRS must be confirmed through objective evidence by nasal endoscopy, CT scans, and MRI. Nasal endoscopy can provide evidence of characteristic mucopurulent discharge, and CT scans can identify the presence or absence of polyps, bony erosion, and differential densities. Magnetic resonance imaging provides a more accurate differentiation of mucin accumulation and thickening throughout the sinus cavities, according to Hoyt 2016. Regarding its treatment of AFRS includes both surgical and therapeutic interventions. Initial management of AFRS includes empiric antifungal therapy in conjunction with systemic corticosteroids, as used in CRS. Treatment failure with this regimen leads to endoscopic sinus surgery. Surgery allows for the removal of the obstruction and evaluation of histology and cell culture to identify the nature of the fungi present. Maintenance therapy consists of topical nasal corticosteroids, according to Gann 2014. Regarding corticosteroids, systemic corticosteroids are initiated postoperatively to reduce inflammation. Nasal corticosteroids can be initiated immediately after surgery or after the sinonasal membranes have had time to heal. Combination therapy of oral and topical glucocorticoids is generally maintained for an average of 2 to 12 months after surgery to suppress local allergic inflammation. At this time, oral glucocorticoids are tapered, and topical glucocorticoids are continued as maintenance therapy, according to Landsberg 2007. Dosing and duration are based on the severity of disease and patient parameters. For typical dosing of corticosteroids, see Table 2 to 4. Regarding antifungals, data are limited supporting the use of oral and topical antifungals for AFRS. Systemic antifungals such as amphotericin B and itraconazole have minimal benefit in managing AFRS, according to Chan 2008. Topical application of itraconazole resolves symptoms and fungal mucin and polyps on endoscopy to patients with refractory AFRS and helps prevent recurrent AFRS, according to Chan 2008. Voriconazole is effective in acute and chronic invasive aspergillosis, according to Qatar 2009. Caspofungin, anidulafungin, and micafungin are effective in refractory invasive aspergillosis, as revealed by CT scans, according to Parida 2006. Caspofungin has been identified as empiric therapy for patients with neutropenia presenting with fungal sinusitis, according to Qatar 2009. Dosing and duration are based on the severity of disease and patient parameters. Typical dosing of antifungal agents is listed in Table 2 to 9. Regarding immunotherapy, fungal immunotherapy consisting of fungal allergens identified by in vitro or skin testing helps treat symptoms and reduce recurrent AFRS, according to Hall 2012. Because AFRS is an immunoglobulin E, abbreviated as IgE, mediated, eosinophil predominated hypersensitivity response, high serum total and fungal-specific IgE fungal immunotherapy targets an activated adaptive immune response, according to Plong 2014. Immunotherapy should be initiated 4 to 6 weeks after surgical intervention, according to Hall 2012. Recent case reports support the use of sublingual immunotherapy for ease of delivery, enhanced adherence, improved symptoms, and improved CT scans, according to Meltzer 2011. Optimal duration of fungal immunotherapy is unclear, with some cases supporting therapy for up to 5 years, according to Hall 2012. Regarding biologics, evidence is limited to support the use of biologics for AFRS. However, omalizumab is an effective treatment for AFRS that is refractory to endoscopic sinus surgery and glucocorticoid therapy by reducing polyp size, according to Evans 2014. Omalizumab can be considered as potential adjunctive therapy in patients with refractory AFRS with moderate or severe asthma, according to Gan 2015. Pause the video and carefully scrutinize Table 2 to 9 summarizing systemic antifungals for FRS. Next we will discuss fungal rhinosinusitis. As a way of introduction, fungal rhinosinusitis encompasses a broad group of conditions caused by fungal infections of the nasal cavity and paranasal sinuses. These conditions vary in clinical presentation, histology, and biological significance. There is much confusion regarding the classification of FRS. However, the most commonly accepted classification divides FRS into two categories, non-invasive and invasive disease, as shown in Table 2 to 10. Non-invasive disease consists of fungal ball and fungus-related eosinophilic FRS, including AFRS. Invasive disease consists of acute invasive, that is, fulminant FRS and chronic invasive FRS, according to Chakrabarty 2009. Fungal colonization occurs when fungal spores are inhaled into the sinuses and lungs. Patients with anatomic abnormalities of the paranasal sinuses or mucosal injury are most susceptible to fungal infections because of nasal drainage and pooling issues. For this reason, FRS should always be considered in patients presenting with CRS. Pause the video and carefully scrutinize Table 2 to 10 summarizing the classification of FRS. Next we will discuss non-invasive FRS. As a way of background, non-invasive FRS consists of localized fungal colonization. It is an asymptomatic and macroscopically visible colonization of the sinonasal mucosa, according to Kayahas 2013. Non-invasive FRS often occurs in patients with intact immune systems and a history of sinus surgery. Non-invasive FRS is thought to grow in areas of mucosa with impaired mucociliary clearance. Non-invasive FRS has two subtypes, fungal ball and AFRS, previously discussed. A fungal ball is a condensed pool of intertwined fungal hyphae that forms in the paranasal sinuses without tissue invasion, according to Nicolai 2009. The maxillary sinus is usually involved, and rarely is more than one sinus affected, according to Kayahas 2013. The mechanism by which fungal balls are formed is unknown, but it is thought that the use of zinc oxide to fill maxillary cavities could lead to their development, according to Nicolai 2015. For unknown reasons, fungal balls are more common in immunocompetent middle-aged or older women, according to Solar 2012. Fungal balls rarely progress to invasive FRS, but some cases have occurred in immunocompetent patients, according to Roby 2009. Regarding its microbiology, although fungal cultures are negative in as many as 65% of cases of fungal balls, Aspergillus fumigatus is the most commonly reported fungal species, according to Solar 2012. Aspergillus niger and Aspergillus flavus have also been associated with fungal balls, according to Fanucci 2013. Regarding clinical presentation and diagnosis, patients usually present with nonspecific symptoms of CRS such as congestion, facial pain or fullness, and purulent nasal discharge. Fungal balls may also be discovered in asymptomatic patients during radiologic examinations, according to Solar 2012. Diagnosis is usually secured through CT imaging, MRI, and surgical procedures, not nasal endoscopy, according to Solar 2012. Diagnosis and identification of fungal species can be confirmed during surgery when chalk-like concretions are found within the sinus, according to Solar 2012. Regarding treatment of fungal balls focuses on eradicating the obstruction and improving sinonasal tract airflow. Endoscopic removal depends on which sinus is affected. Recurrence after surgical removal is uncommon. As such, treatment with oral or topical antifungal agents offers no clear benefit, according to Nicolai 2009. Next we will discuss acute invasive FRS. As a way of background, acute invasive FRS rapidly progresses with days to weeks. Acute invasive FRS tends to spread aggressively and often has a fulminate course. Fungal infections are thought to develop in the nasal cavity and spread to the paranasal sinuses. Extension into the eye, brain, palate, and skin can occur, according to Kayahas 2013. Diagnostic criteria for acute invasive FRS require disease presentation to occur in less than 4 weeks, according to Solar 2012. If not diagnosed and treated in a timely manner, acute invasive FRS can be fatal. Acute invasive FRS primarily involves immunocompromised patients but has also occurred in immunocompetent patients. Populations most at risk of acute invasive FRS include those with uncontrolled diabetes mellitus, those receiving chemotherapy, bone marrow transplant recipients, patients with HIV, and individuals taking chronic oral corticosteroids, according to Solar 2012. Regarding the microbiology, Aspergillus species are the most common pathogens identified in acute invasive FRS. Members of the class Zygomycetes, such as Rhizopus, Rhizomycor, Mucor, and Absidia species, are also commonly identified in acute invasive FRS, according to Dwighalo 2016. Hyaline molds such as Fusarium spp, Pseudosporium species, and Pachylomyces species are less common but emerging pathogens, according to Kayahas 2013. Although correlations are insufficiently consistent to guide empiric therapy, a predisposition to certain fungal species has been associated with medical comorbidities, according to Solar 2012. For example, patients with hematologic malignancy usually present with Aspergillus flavus, Mucor, Fusarium, and Penicillium species, according to Chen 2011. Regarding clinical evaluation and diagnosis, presentations of acute invasive FRS may vary. Similar to non-invasive FRS, patients often present with CRS-like symptoms, including congestion, facial pain and pressure, and drainage. If the disease has spread from the sinuses to the orbit, patients may also present with headaches, ophthalmoplegia, proptosis, and vision loss. Patients presenting with CRS symptoms with known or potential immunosuppression should receive an increased level of care, according to Solar 2012. Patients presenting with suspected invasive fungal disease require rapid clinical assessment. Sinonasal endoscopy is usually performed to immediately identify fungus within mucosa, blood vessels, soft tissue, or bone. Special fungal stains like calco-fluor white are used to visualize fungal hyphae, according to Solar 2012. Non-contrast CT may help identify bony changes and hypoattenuating mucosal thickening of the affected areas to determine disease progression. Magnetic resonance imaging is favored for evaluating retroantral, intraorbital, or intracranial spread but can delay definitive diagnosis because of image processing times, according to Solar 2012. Regarding treatment of invasive FRS involves reversing the underlying medical condition or immunocompromised state, if warranted, surgically eradicating all necrotic tissue, and initiating systemic antifungal therapy, according to Solar 2012. The extent of surgery is based on the macroscopic appearance of tissues. Debridement occurs until healthy-appearing, bleeding tissue is reached, with the intent to eradicate most of the fungal invasion before initiating antifungal therapy. See Table 2-9. The involved fungal species should be identified to select the appropriate antimycotic therapy. However, the time taken to treat the patient significantly affects patient survival. Therefore, empiric antifungal therapy should be initiated with intravenous amphotericin B to cover Aspergillus species and Zygomycetes. Lipid-based formulations of amphotericin B are preferred to limit the risk of renal damage. Other antifungal medications for acute invasive FRS include voriconazole, posaconazole, itraconazole, isavuconazole, and echinocandins. Voriconazole is approved for first-line treatment of invasive aspergillosis and is preferred once histopathology identifies Aspergillus as the offending species. Posaconazole, which is approved for second-line treatment of invasive aspergillosis and refractory disease, covers both Zygomycetes and Aspergillus, according to Carthouse 2011. Posaconazole can be administered orally and is a good option for prolonged outpatient regimens, according to Langner 2008. Isavuconazole, FDA approved in 2015, has been proven safe and clinically effective in treating invasive mucormycosis. A case report revealed that isavuconazole therapy should be considered in patients with invasive mucorales that is refractory to amphotericin B, according to Ahmed 2016. Echinocandins are approved for second-line treatment of invasive aspergillosis in patients who are refractory to or intolerant of first-line agents, according to Carthouse 2011. In combination with amphotericin B, caspofungin has synergistic effects, according to Spellberg 2005. Therapy duration depends on disease severity, with treatment of 2 to 14 months in some cases, according to Pageler 2016. Therapy persists until complete resolution of all symptoms of fungal infection for at least 2 weeks, resolution of radiographic findings, and return of negative fungal cultures, and until underlying risk factors such as neutropenia or diabetic ketoacidosis have been corrected. Next we will discuss chronic invasive FRS, as a way of background. Whether chronic invasive FRS and granulomatous FRS are two separate diseases or different presentations of the same phenotype is unclear, according to Denning 2017. Chronic invasive FRS occurs worldwide and presents in both immunocompetent and immunocompromised patients. Granulomatous FRS usually occurs in immunocompetent patients in the geographic region between Sudan and India, according to Denning 2017. Chronic invasive FRS typically lasts more than 12 weeks. Chronic invasive FRS and granulomatous FRS present as dense accumulations of hyphae that are often accompanied by vascular invasion and inflammatory reactions of the affected area. These two types of FRS may affect any paranasal sinus but are usually found in the ethmoid and sphenoid sinuses, according to Chakrabarti 2009. Regarding the microbiology, fungal-specific cultures of chronic invasive FRS can grow a variety of species, including demaciaceous molds, that is bipolarized, curvularia, and alternaria species, aspergillus species, and zygomycetes. Aspergillus flavus is the most common species associated with granulomatous FRS. Regarding clinical evaluation and diagnosis of chronic invasive FRS is established by histopathology of endoscopically removed fungal samples that reveal fungal hyphae infiltrating mucosa, blood vessels, or bone. Surrounding tissues are often inflamed and necrotic. Regarding treatment, management of both chronic invasive FRS and granulomatous invasive FRS consists of surgical debridement and antifungal therapy. Amphotericin B, voriconazole, and itraconazole are all effective first-line therapies post-debridement, according to Denning 2017, and Rupa 2015. Amphotericin B and itraconazole combination therapy are more efficacious than amphotericin alone, according to Rupa 2015. Echinocandins such as caspofungin, anadulafungin, and micafungin are usually reserved for salvage therapy, according to Rupa 2015. Therapy duration depends on disease severity and has been reported to be 6 to 18 months. The risk of recurrence requires prolonged therapy, according to Rupa 2015. Regarding medication therapy management, to engage patients in their health care and encourage shared decision-making, the AAOHNSF developed patient information sheets for providers to use as teaching aids, as shown in Box 2-1, and Box 2-2. These patient information sheets address the causes and signs and symptoms of both VRS and ABRS. In addition, they provide valuable information about when antibiotic therapy is needed and why antibiotics are not always warranted, thus supporting antimicrobial stewardship efforts. Acknowledgement of the importance of patient education in treating rhinosinusitis sets a precedent for all health care providers to ensure that they are empowering patients to take an active role in their health care. Clinical pharmacists can implement medication therapy management programs revolving around comprehensive medication reviews, medication adherence, antimicrobial stewardship, and patient education, which can enhance patient care initiatives and improve quality. Completion of comprehensive medication reviews in patients with CRS and FRS can provide insight into the management of underlying conditions such as diabetes or asthma. Early identification of drug therapy problems, including medication adherence issues, and unmanaged disease states can lead to early interventions and ensure optimal therapeutic outcomes and prevention of acute exacerbations of CRS or immunocompromised states in which a patient would be more susceptible to disease. Medication adherence plays a large role in managing rhinosinusitis conditions. Non-adherence to rhinosinusitis medications may arise because of cost issues, limited access to health care, or lack of patient education. Through medication therapy management initiatives, clinical pharmacists can work with patients to ensure understanding of the importance of medication adherence and identify tools and resources to optimize therapeutic outcomes, including working with providers to recommend alternative therapies and conducting patient follow-up calls. Medication therapy management initiatives revolving around antimicrobial stewardship are crucial in both inpatient and outpatient settings. Antimicrobial stewardship programs improve patient outcomes by selecting appropriate therapy to decrease both microbial resistance and the spread of infection. This is especially true of patients presenting with VRS, as depicted in the patient information sheets developed by the AAOHNSF. Working with patients and providers to select appropriate supportive therapies for VRS can help reduce antimicrobial overprescribing for viral infections, according to Drekignia 2015. Pause the video and carefully scrutinize box 2 to 1 summarizing patient information sheet on diagnosis of acute sinusitis. Pause the video and carefully scrutinize box 2 to 2 summarizing patient information sheet on treating acute bacterial rhinosinusitis. And now we will finally discuss practice points. 1. Rhinosinusitis is a complex disease state that presents in a variety of forms and with complications ranging from irritation to death. Clinical pharmacists should be able to distinguish between the different types of rhinosinusitis to ensure that patients receive optimal therapy in a timely manner. 2. Management of VRS should be limited to symptomatic relief. Antimicrobial therapy should not be initiated for VRS. 3. Watchful waiting can be implemented in patients who present with ABRS if there is a guarantee for follow-up. Otherwise, antimicrobial therapy should be initiated on diagnosis. 4. Confirmation of the presence or absence of nasal polyps in patients presenting with CRS is necessary to ensure proper medical and therapeutic management. 5. Early diagnosis and treatment of allergic FRS can prolong the need for endoscopic sinus surgery and subsequent postoperative therapy. 6. Early identification and treatment of FRS is essential because of the possibility of fatal implications. 7. Patient education and follow-up is of utmost importance to ensure that patients are adherent to their therapeutic regimens in effort to prevent recurrence of rhinosinusitis. In conclusion, rhinosinusitis is a complex set of conditions that range from acute to chronic, with complications ranging from mild signs and symptoms to death. High-quality evidence is limited, and current treatment guidelines are conflicting. Thus, pharmacists should understand the available treatment options to provide optimal patient care. Thank you.